topic of today's lecture is childhood nephrotic syndrome, and I'm Dr. Shenal, Thalgahagoda, consultant pediatric nephrologist at Peradeniya. So let's start with an introduction. Nephrotic syndrome is a syndrome characterized by massive proteinuria. This is defined as a urine protein excretion of more than 40 milligrams per meter squared per hour, or a urine protein creatinine ratio of more than 200 milligrams per millimole. We usually don't do 24-hour collections to measure the protein excretion. So usually it's a clinical decision based on the urine pool report, which shows 3+ proteinuria. But if you need a definition, you need to stick to one of these. Hypoalbuminemia, the other feature of this condition is hypoalbuminemia. Here the serum albumin in nephrotic syndrome should be less than 25 grams per liter. These patients are also edematous, and most of them do have hypercholesterolemia. So basically the important features again: massive proteinuria, hypoalbuminemia, and edema. So it's a very distressing condition. So these children are severely edematous, and this edema they can have quite significant scrotal edema as well. So it's a very distressing condition, and it is also associated with quite significant morbidity, though mortality is rare. Nephrotic syndrome is the commonest glomerular disease in children, and more than 80% of patients are steroid sensitive. So this is what differentiates childhood nephrotic syndrome from adult nephrotic syndrome. Most childhood patients are steroid sensitive, whereas in adults the steroid sensitivity percentages are much less. Another important feature is that childhood nephrotic syndrome is characterized by a relapsing and remitting course. So you have relapses, you treat the relapses, and the child goes into remission, and they have frequent relapse, and they have subsequent relapses thereafter. This is the case in most patients. In adults, you find a lot of patients with rumbling proteinuria. The proteinuria goes from quite significant to low grade, and waxes and wanes, more than being sort of clear-cut relapses and remission. Moving on to the natural history. So only about 20 to 30% of patients will have a single episode and go into complete remission thereafter. Most of the patients, more than 70%, will have relapsing disease, as I have just mentioned, or some of them even become resistant to steroids, necessitating second-line agents to induce remission. But what is good about this disease is that the majority of patients will go into spontaneous remission in the second decade of life. So between 10 and 20 years, during that period, most of them will go into spontaneous remission. So what we are doing by managing this condition basically is buying time till nature takes over and the patient goes into spontaneous remission, which is the case in the vast majority, but not all. Histologically, childhood nephrotic syndrome encompasses basically three main histological entities. Minimal change disease, which is associated with a better prognosis, is the histological entity found in the majority of childhood patients. So more than 80% of minimal change disease more than 80% of childhood nephrotics will have minimal change disease, and this entity is associated with exquisite steroid sensitivity, which is seen in more than 90% of patients. More than 90% of minimal change disease will respond to steroids. Focal segmental glomerulosclerosis, or FSGS, is seen in further 15% of patients with childhood nephrotic syndrome. Here the steroid sensitivity percentage is much less. It's around about only about 50% of these patients are about 30 to 50% are steroid sensitive. and mesangial proliferation is somewhere in between, accounting for 5% of patients with a steroid sensitivity percentage of around 50%. So in adults, minimal change disease is not the most seen entity, whereas in children, minimal change disease is by far the most seen entity, which is why the steroid sensitivity rates in children are much more than in adults. The pictures of slides show FSGS. You see sclerosis in the middle of the glomerulus, and mesangial proliferation, where there is no sclerosis but proliferation of the mesangium and the matrix of the glomerulus. Moving on to epidemiology, the peak incidence of childhood nephrotic syndrome is between the ages of 2 and 6 years, and it is more common in boys with a male to female ratio of 2 to 1. Now, the incidence has been shown to be 2 to 4 per 100,000 children in the United Kingdom, and interestingly, it has been shown to be 6 times more common in the UK Asian population. And remember, not only is the condition more frequent or more common in Asians, Asians also tend to have more severe disease. So sometimes extrapolation of Western data may not be suitable to our population. So when talking about childhood nephrotic syndrome, you need to know a few definitions, because these definitions define how you're going to classify the patient, and that classification is the basis for your management decisions. So based on this, and these are the recommendations given by a large-scale study done in the 1970s on childhood nephrotics, and this study basically studied this disease in detail. It was called the International Study of Kidney Diseases in Children, or ISKDC, and all these definitions are based on the findings of that study. So here, a frequent relapser was defined as a patient with 2 or more relapses within the first 6 months of the disease, or a patient with 4 or more relapses within any 12-month period. An infrequent relapse obviously has a lesser number of relapses, so less than 2 relapses in the first 6 months, or less than 4 relapses within any 12-month period. Steroid dependence has been defined, or was defined, as 2 consecutive relapses while on alternative prednisolone, or within 14 days of cessation of steroids. People now tend to consider even a single relapse while on alternate day steroids as steroid dependence. Steroid resistance is still defined as failure to attain remission despite 28 days of prednisolone at 60 milligrams per meter squared, which is the treatment regimen for the first episode. So you need to know these definitions, because your management decisions are based on these definitions. So let's just look into the clinical features, the history, examination, and then move on to the investigations first. So what is characteristic of the edema in childhood nephrotic syndrome is that it begins periorbitally. It's worse early morning, and it progressively spreads to the rest of the body. So this differentiates renal edema, or the edema seen in nephrotic syndrome, from other conditions where cardiac edema is more dependent. Hepatic causes or constrictive pericarditis begins in the abdomen and progresses, and patients with lymphedema have unilateral or asymmetrical edema, as do patients with venous occlusion and cellulitis. So when you take the history, it's important. When the parents will usually complain that their child is swollen, so you need to define, or you need to find out where the swelling began, and if it is periorbital, that suggests a renal cause. So in your history, you need to exclude other causes of edema, patients with acute glomerulonephritis will have edema. There can be cardiac causes of edema. Edema can be angioedema due to allergic conditions, and it can be hepatic either. It can be hepatic as well. Nephrotic syndrome, apart from idiopathic nephrotic syndrome, can also be caused by certain other conditions like SLE, like henoxyoma purpura, like mesangial proliferative glomerulonephritis. So the patient might have features of these other conditions in the history. So if the patient has rashes or arthropathy, you need to think of SLE or HSP. Right? So in your history, you need to come out with, you need to look for evidence of other causes of nephrotic syndrome. And the three main complications of the nephrotic in relapse are hypovolemia, sepsis, and thrombosis. So your history also should look for the possibilities of these three entities. So hypovolemia, you need to define the urine output of the patient, and features and other features of hypovolemia like lightheadedness, dizziness, and hypotension in your examination. You need to look for features of sepsis and features of thrombosis as well, because thrombosis is a complication of nephrotic syndrome. Right. When we move on to examination, you need to weigh the child, get the height, and calculate the body surface area. Now this has to be done in all patients because it has implications on your management. And also look at the distribution of edema, because we said the distribution of edema gives you a clue as to the cause of the edema. And the assessment of circulation is of utmost importance, because circulatory compromise, we said hypovolemia is one of the complications. Circulatory compromise is very common in patients with nephrotic syndrome. So a thorough evaluation of the circulation, and if you find that the circulation is problematic, you need to address that immediately, right? So you need to check the pulse rate and the pulse volume, look at the capillary refilling time, and this line of warm-cool demarcation is basically looking at hypoperfusion. So these patients, if they are hypovolemic, they will have cold peripheries, and this cold periphery, there'll be a line of warm-cool demarcation. So the central part of the body will be warm, and sometimes part of the limb will be warm, and the peripheries will be cold. So this line of demarcation will move more periphery when you correct the hypovolemia. So this can be used as a measure, a clinical measure of the response to therapy. So blood pressure and pulse pressure are of extreme importance, and also in your examination you need to look for features of infection. And also, as I did mention in the history, you need to look for features of underlying systemic disorders like HSP and lupus as well, because these conditions can present with nephrotic syndrome and their management is completely different. So what are the investigations you do? These are basically the investigations you do in all patients with nephrotic. So a full blood count is not, does not give you a lot of information, but your hematocrit would be raised if the patient was hypovolemic. So normal hematocrit would be around 35 to 40 in children. So in these patients it can go up to even 50, which basically occurs due to the intravascular fluid moving out to the extravascular compartment, and that leading to concentration of the red cells. So your hematocrit goes up. And if there is an infective focus which has precipitated the relapse or the episode, the white count may be elevated. Urine fill report is of utmost importance and gives you a lot of information as well. So your protein, the urine protein would be 3+ or more, which is basically all we do to assess the urine protein level. We don't do the protein creatinine ratio routinely in all patients. We don't do 24-hour collections. We hardly ever do 24-hour collections. Red cells, remember, red cells are not part and parcel of nephrotic syndrome, but they can be seen in up to 20% of patients even with minimal change disease. So it's not an unusual feature, but it is not a feature of the disease. It is not a typical feature. Right. Pus cells, in the urine would indicate that there is an could indicate that there is an ongoing urine tract infection. And if there are casts, like red cell casts or granular casts, that would indicate an atypical presentation as well. You need to assess your renal functions in the form of creatinine and also do the serum electrolytes. Serum albumin is essential to diagnose a relapse. Your albumin here would be less than 25 grams per liter, which is basically the definition of nephrotic syndrome. And your serum cholesterol is almost always elevated. So these investigations are needed in all patients with presenting with features of nephrotic syndrome. Patients who present atypically, like with macroscopic hematuria, we said microscopic hematuria may be seen as not essentially an atypical feature, but macroscopic hematuria, remember, is an atypical feature. If your patient has a vasculitic rash, if the patient has arthropathy, these are all atypical features. So in these patients, you need to expand your investigations. You need to do an ASOT. You need to do, if the patient is hypertensive, that again is an atypical feature in the majority. So in these patients, you need to do your ESR, you need to do your antistreptolytes and O-titer, you need to do your ESR, complement levels, ANA and double-stranded DNA, looking for lupus. Hepatitis B and C serology, because these patients with these two hepatitis causing viruses can cause nephrotic syndrome, as can HIV. So these screening investigations are necessary in patients with atypical presentations. Right, so moving on to management. What are you going to do in the ward? So on a daily basis, these patients' urine albumin needs to be tested, and you need to test the first morning void. The first voided sample needs to be tested for proteins, because towards evening, when the child is mobile, they can have what is called orthostatic proteinuria, which is not part and parcel of the condition. So we need to test the early mornings urine protein, and that is significant. And that shows protein. That is true proteinuria. You need to maintain a strict input and output chart on a daily basis, right? And your fluid management would depend on the input and output. And these children need to be weighed on a daily basis, especially if the patients are breastfeeding, because when they're breastfeeding, you can't really monitor the input and output accurately. So in these patients, weight is a good measure of the fluid status. All patients need to be reviewed a minimum of 3 times a day, especially if they're significantly edematous, because their volume status needs special attention. Always remember, the edematous nephrotic is at risk of hypovolemia, and you need to detect and treat this early. So I said at the onset that the main line of therapy for childhood nephrotic syndrome is corticosteroids in the form of prednisolone. So for the first episode, how do we treat this? How do we use prednisolone? For the first episode of nephrotic syndrome, prednisolone is given at 60 milligrams per meter squared daily for 28 days, followed by 40 milligrams per meter squared on alternate days for a further 28 days. Now this is the original ISKDC regimen proposed by the study I mentioned earlier, and this is what is practiced in a lot of units worldwide. But this study basically recommended that prednisolone be stopped at once at 40 milligrams per meter squared every other day for 28 days. Stop it abruptly. But now most units taper off the prednisolone. Say you go from 40 to 30, 20 to 15 to 10, like that, so on. Over a period of time, you taper off the dose. So most units practice a tapering dose regimen, and there are various other regimens which I will mention because we use other regimens in our unit as well. But for your exam purposes, this is what you should what you should remember as the therapy for nephrotic syndrome. A relapse is treated slightly differently. You give the prednisolone at 60 milligrams per meter squared daily till the patient goes into remission. So remission is nil or trace proteinuria for 3 consecutive days. So once the patient goes into remission, you follow it up with 40 milligrams per meter squared every other day for a further 28 days, and you taper it off thereafter. Right? So again, I stress, this is what you should remember for your exam purposes. I'm going to just touch on what we do in our ward, because when you move on to your clinical professorial appointments and you come to the ward, we don't strictly stick to this regimen, so you'll need to know what we do in our ward. So what we practice is we classify patients as early responders and late responders. So an early responder is a patient who goes into remission within 14 days of prednisolone at 60 milligrams per meter squared. These for the first episode. So those going into remission within 14 days of starting prednisolone at 60 milligrams per meter squared are classified as early responders. If they take longer than 14 days to go into remission, they are classified as late responders. So for an early responder first episode, you give 60 milligrams per meter squared daily for 4 weeks, and then we switch from 60 daily to 60 every other day, and we taper that dose over a period of 8 to 12 weeks. So the total duration of steroids for an early responder in the first episode would be 4 plus 12, 16 weeks. For a late responder, we give prednisolone at 60 milligrams per meter squared daily for 6 weeks, followed by, so here it's 6 weeks and not 4 weeks, it's a longer course of steroids, and we follow it up by 60 milligrams per meter squared on alternate days, and we taper that over a period of 18 weeks. So the total duration of steroids is 24 weeks, or almost 6 months. So this is what we practice in the ward. I've just mentioned it because you need to know this when you come to the clinical professorial appointments, but for your exam purposes, please stick to the ISKDC regimen. We treat a relapse with 60 milligrams per meter squared daily till the patient goes into remission, follow it up with 60 milligrams on alternate days, and this dose is tapered over a variable period of time depending on the frequency of relapses. If the child is relapsing very frequently, we'll give a prolonged taper and keep really a small dose of steroids going on for a long time. If the child is an infrequent relapser, having just 1 or 2 relapses a year, we'll taper the steroids off over about 3 months. So I've mentioned that steroids are the mainstay of therapy, but when patients are having problems with steroids, with response to steroids, or if they're having side effects of the steroids, you need to add in a second line agent. So why do we need to add in second line agents? Because about 40% of patients will have very frequent relapses or will have steroid dependent disease. So these patients need multiple courses of high dose steroids, and they relapse while on steroids. So you need to continue steroids for a long period of time, which is not ideal and which entails the side effects of steroids, which we all know. So in these patients, you need to add the second line agent to spare the patient from the use of steroids, or as a steroid sparing agent. So I've mentioned this, steroid treatment with prednisolone is associated with significant side effects. We need to spare the patient from the use of steroids. And the second indication for using second line agents is as a remission inducing agent if the patient becomes steroid resistant. So we defined steroid resistance earlier as failure to attain remission despite 60 milligrams per meter squared of prednisolone given for 28 days. So at the end of that, if you still haven't attained remission, steroids are not going to be able to induce remission. So you need something else to push the patient into remission, which is where these second line agents come in. So I've mentioned the side effects of steroids. So they can have a lot of behavioral problems. They can be aggressive and hyperactive. Older children tend to be more depressive. They can have quite significant Cushingoid features. They can have unsightly purple striae on the abdomen. And long-term steroids will always have detrimental effects on growth. So these two patients both are 13 years of age, and you can see the detrimental effects of steroids on height. They can also cause cataracts. The boy of impaired stature is wearing specs because he has cataracts, and they can also cause hypertension, diabetes, osteoporosis, and a multitude of other side effects. So what are the second line agents we have in our armamentarium? We have levamisole, we have the alkylating agent cyclophosphamide, we have the calcineurin inhibitors cyclosporine and tacrolimus, we have mycophenolate mofetil, and we have rituximab. So these are the available agents. Let's just touch on each of them. So levamisole is originally it was basically worm treatment, it was an anti-helminthic agent, but it has immunomodulatory properties, and it is useful for patients with mild disease. So that's the dose, and you need to give it for prolonged periods of time. So it's sometimes 2-3 years, sometimes even longer than that. And it is a relatively side effect free drug, or relatively safe drug, but patients can get leukopenia, they can get slight GI disturbances, and they can have a vasculitic rash, which if this occurs, you need to stop the drug immediately. But by and large, it is quite a safe agent to use, and it has no remission inducing properties, which is why you cannot use levamisole for steroid resistant disease. It is useful only as a steroid sparing agent, and that being said, only for patients with milder forms of the disease, but it is safe. Cyclosporine is at the other extreme. It's a calcineurin inhibitor. It has both steroid sparing and remission inducing properties. That is the dose, and the duration, again, you need to give it long term, very often longer than 2 years. One thing important about cyclosporine is that it is a nephrotoxic drug. So you're giving a nephrotoxic drug to a potentially renal damaging condition. So you need to use it with caution and only when required. It is the most potent agent we have for routine practice. So it should be used only for patients with very severe disease, severe dependence, or for steroid resistance. It is the drug of choice. So nephrotoxicity I've mentioned as its side effect. Patients also have hypertrichosis, which is excessive hair growth on the body. They can have gingival hypertrophy, or I'll show you a picture in the next slide, and they can also cause hypertension, hyperkalemia, and disturbances in magnesium. So you need to monitor renal functions in these patients. It is of utmost importance. Ideally, they should be done monthly, but for practical purposes, we do them every 3 months. So this shows the hypertrichosis. This patient has, you see on the forehead all over, there is hypertrichosis, and also he has gingival hypertrophy. So this is basically quite unsightly, your gum hypertrophy, and interestingly, it is amenable to maintaining good oral hygiene. So all you need to do is advise these patients to brush their teeth very regularly and maintain very good oral hygiene, and you can minimize this gingival hypertrophy if you do so. So hypertrichosis, remember, it can be quite unsightly, especially in girls, and which it leads to a lot of non-compliance, especially the teenage girls. And remember, it's worse in Asians. So let's move on to the next agent, cyclophosphamide. Again, this is an alkylating agent which has both remission-inducing and steroid-sparing properties. So it can be given intravenously or orally. So orally, it's given for a period of 8 to 12 weeks on a daily basis. Intravenously, it's given as monthly pulses for 6 months. And cyclophosphamide has a whole host of side effects. You can get bone marrow dyscrasias like leukopenia. You can get hemorrhagic cystitis, which is again amenable to maintenance of maintenance of adequate hydration or good fluid intake. It can cause gonadal toxicity in the form of azoospermia or gonadophilia in females. It can cause future malignancies in the form of leukemias later on, and a lot of patients develop alopecia, but remember, the alopecia resolves with the cessation of the drug. So you need to monitor your full blood counts on a weekly basis while they are on cyclophosphamide, and you need to stop or reduce the dose if the counts tend to fall. Where would you use cyclophosphamide? Cyclophosphamide in potency, it's more potent than levamisole, but it is not as potent as cyclosporine. So a patient who is not responding to levamisole, but the disease is not severe enough to warrant the use of cyclosporine rather, that's where I would use cyclophosphamide. This drug, people in the West it has fallen out of favor in the West, but still we do use quite a bit of it in this part of the world. So I've mentioned the side effects. So you can get severe alopecia, bone marrow suppression. This patient is a patient of ours who developed hemorrhagic varicella for cyclophosphamide. So the next the medic second line agent is mycophenolate mofetil. This is an antimetabolite, again has steroid sparing and remission inducing properties. Again, it needs to be given long term, and this drug, the main side effects are gastrointestinal. Some patients do get very severe GI disturbances in the form of diarrhea, severe loss of appetite and cachexia, but some patients tolerate it quite well, and they can also have leukopenias as well. So you need to monitor your full blood counts regularly, maybe on a monthly or every 2 monthly basis. And where I would use mycophenolate mofetil, it's similar to the place you'd use cyclophosphamide. So in patients who are not responding to levamisole, but the disease is not severe enough to warrant cyclosporine. Rituximab is basically a new, it's not that new any longer. This drug is reserved for patients with very, very severe disease who are relapsing while on cyclosporine as well. So it's CD20 anti-CD20 monoclonal antibody, very expensive, and it is given for patients who relapse while on cyclosporine as well. So just to summarize your therapeutic modalities with the use of second line agents. So if patients have frequently relapsing mild steroid dependence, you start with prednisolone and you continue low dose levamisole. If the patient relapses on levamisole plus while being on significant dose of prednisolone, say more than 0.5 milligrams per kg, you can start with cyclophosphamide or MMF, and you can, if that fails, you can move on to cyclosporine. So for patients relapsing on very high doses of steroids, we tend to start with cyclosporine, but you can always try something like MMF and then move on to cyclosporine later on. For patients relapsing while on steroids and prednisolone, you need to individualize, and that's where rituximab comes in. So what are the indications for renal biopsy? So because the vast majority of patients with childhood nephrotic syndrome have minimal change disease, we do not do biopsies on all nephrotics. Biopsies are done only for specific indications. Adults, in the adult population, a renal biopsy is mandatory in all patients with nephrotic syndrome. So if the patient has steroid resistant disease, whether it be primary or secondary resistance, secondary resistance where the patient responds to steroids initially, but then subsequently, during subsequent relapses, he stops responding to steroids. So anyway, whether it is primary or secondary, if the patient is steroid resistant, you need to do a biopsy to find out what is going on. If the onset of the condition is at an age less than 6 months, because of the possibility of congenital nephrotic syndrome, you need to do a biopsy. Because if it is congenital nephrotic syndrome, there is no point in subjecting the patient to the use of steroids and other toxic medications. If there are features of secondary causes like HSP or SLE, if the patient has a rash or arthropathy, then obviously you're going to need to do a biopsy because the treatment would be quite different. If the patient has deranged renal functions with nephrotic syndrome, and this renal functional derangement is not attributable to hypovolemia. Remember, if the patients are overtly hypovolemic, they will obviously have deranged renal functions. But if the patients are euvolemic and not hypovolemic and still have deranged renal functions, then you obviously need to do a biopsy because that is not a minimal change disease. Microscopic hematuria, we said, is not that atypical a feature, though it is not a feature of the disease, but macroscopic hematuria is an indication to do a biopsy. But patients with persistent microscopic hematuria, even when they go into remission, especially if it is associated with hypertension, you need to do a biopsy on these patients. And if you do the complement levels and they are low in a nephrotic, then again you do need to do a biopsy. So basically, a biopsy is indicated when you are suspecting an entity other than minimal change. So if there is nothing to suspect, non-minimal change disease, you do not need to do biopsy. So let's end with a summary. So childhood nephrotic syndrome is associated with significant morbidity and maybe a little bit of mortality as well. Management is defined by the ISKDC recommendations. Corticosteroids are the mainstay of therapy, and second-line agents are required for frequent relapses in patients with steroid-dependent and steroid-resistant disease. Thank you.